Hello, everybody. We're back. Going to hit chapter 19 and we're going to do some lab midterm review. It's tough. Almost here. Okay. Here we go. So don't hold. There we go. All right. Share. Here. Take this. And begin. Okay. Put it up. Okay, so this is going to deal with diseases of the respiratory tract. And we have to remember that this is one of the body systems open to the outside world at the nose and the mouth. So it's a definite port of entry. So it shouldn't surprise you that there are a lot of infectious diseases that hit this system. The respiratory tract has two parts, right? The upper respiratory tract runs from the mouth to the epiglottis, which is the doorway into the voice box, right? The larynx. And from there into the trachea, from there into the bronchi, and then down into the bronchioles. Okay. The upper and the lower respiratory tract can definitely get infected. Okay. Upper respiratory more often than lower respiratory, but we can hit the respiratory with viruses, with fungus, with bacteria. There are diseases in all the different categories. Okay, if you look at the upper respiratory, it's designed to keep the lower respiratory relatively disease-free because it's lined with a special kind of tissue. Okay, and this tissue is pseudostratified ciliated columnar epithelium. Let's write that down. That's a mouthful. Okay. And the advantage of this is that it contains cilia, right? Cilia, but it also produces mucus, which helps to trap pathogens and particulates. And then the pseudostratified ciliated columnar epithelia, the cilia on those, are going to move that mucus that has the particulates and the pathogens in it up towards the nose and the mouth. And then you can either spit it out or you can swallow it. Okay, you might think, ooh, yuck. But by doing that, you keep it out of the lungs. The lungs are made up primarily of simple squamous epithelium. Okay. That's the bulk of the lung tissue, and it's very delicate and easily damaged. And so we want to keep junk out of there as much as possible. And that's a big part of what the upper respiratory does for us. We should also point out that there's tonsils in the back of the throat, in the back of the pharynx, and we already know that they intercept the ingested and inhaled pathogens and take care of a lot of them, but they don't get 100% of them. So that's why this other safeguard is in place. If you have problems with the operation of the cilia here, such as if you smoke, okay, what happens is that the cilia get paralyzed because of the buildup of carbon monoxide and they stop moving. And then all of that junk drops down into the lungs and damages it. Okay, it's a hallmark of a disease called emphysema. Okay, and one of the problems associated with emphysema is lung infections. Okay, which shouldn't surprise you. When we swallow, either liquid or solid, we close off the larynx so that we don't get food and liquid down into the trachea because of the action of the epiglottis and the soft palate, which keeps the food out of the nasopharynx and the nasal cavity and your trach, right? And that directs everything down ultimately to your stomach, where it gets an acid bath and that sterilizes a lot of what you ingest. And then as we pass through the stomach, we're going to find out that we actually touched on it in the previous chapter, that there's something called MALT, which is an acronym that stands for mucosa associated lymphatic tissue. Which is found not only in the mucosa of the digestive, but also of the respiratory system. And it's made up of macrophages and lymphocytes that intercept stuff trying to get into the blood and keep you from getting a blood infection. Okay, so we have these defenses that are built in. Okay, Notice that the sinuses are connected to the nasal cavity. You can see up here why they're called the paranasal sinuses. And so this is why sometimes if you get sinusitis, right, it feels like your eyes are going to pop out of your head because of the location of these chambers, right? So the nasal cavity is actually much bigger than you think, right? It goes all through here and back here, connected by little pathways through the bone, okay? So there's nasal hair. These are called vibrissae. That protect the respiratory system from big particulates. They act as filters. We've talked about the pseudostratified ciliated columnar epithelium, right? And you're going to find that in the trachea and in the nasopharynx. And in the nasal cavity. Okay. And so the idea is that we direct the junk either into the nose and out, right? Or we swallow it and get it down to the digestive system where those defenses can take care of it. And we don't bother the lungs, right? Complement and antimicrobial peptides, macrophages, and IgA are also in here, right? Complement, remember, helps antibodies destroy pathogens. Okay. Antimicrobial peptides basically punch holes in membranes. Cytokines attract white blood cells. Okay. The macrophages eat invaders. And boost lymphocyte activity. And IgA is antibody that's found in milk, tears, mucus, sweat, and saliva. All those help out. Let's talk about the normal inhabitants of the respiratory. Some of these can cause big problems. Strep pyogenes is something that we commonly find in the oral cavity. Okay. Haemophilus influenzae, Streptococcus pneumoniae, and Neisseria meningitidis all are pathogens, right? And what are the diseases? Well, pneumonia. Haemophilus influenza got the name accidentally, okay? Flu is caused by a virus, and it was thought that because there were often secondary infections with this bacteria, that this caused the flu, okay? But it doesn't, it's just a secondary infection. This is the agent, one of the agents of meningitis, right? And this strep pyogenes, right, is one of the agents in cavities. Gingivitis. Okay. And periodontal disease. The normal lung microbiome, meaning the normal bacteria and microbes that live there, is different in patients that have certain conditions like COPD. Okay, you might not have seen that before. That stands for chronic obstructive pulmonary disease. Okay. Candida albicans can grow on mucosal surfaces. Candida albicans is a fungus. Okay. Smokers and non-smokers can have different normal inhabitants as well, right? Candida albicans, sometimes in people with suppressed immune system, produces a condition called candidiasis. Where your tongue gets white and fuzzy because of the growth of the yeast that causes candidiasis. Okay. Normal biota, meaning our normal inhabitants, lock out a lot of pathogens by taking space away from them, right? Lactobacillus can suppress Corynebacterium tuberculosum in the sinuses, okay? And so here you can see the upper and the lower respiratory tract, the natural defenses, right? And the normal inhabitants, the normal inhabitants. Okay? So let's talk about some of the diseases that can hit the respiratory, okay? And we'll also discuss otitis media, rhinitis, and a few other diseases as well. And then two bacteria that can produce dangerous pharyngitis, right? Pharyngitis, you know better as sore throat. So, pharyngitis, sore throat. Okay. Symptom: pain, inflammation, reddened or swollen mucous membranes, swollen tonsils, bad breath, white packets visible on the walls of the throat, which can indicate strep infection. They can be caused by bacteria and are very painful. Some are caused by viruses that are more likely to be accompanied by fever, headache, and nausea. There's a lot of nerve endings in your throat. Okay, so when you get a sore throat, it hurts. It's very, very painful. Okay, you can see here some examples, right? See the white spots. Let me get different pen color here. Okay, green. Right, see those white spots? Yeah, those are ulcerations. Okay, and that is an indication of infection. And this is very painful. Okay. So one of the things they'll give you for sore throat, things like to treat the symptoms, things like aspirin, ibuprofen. Okay. And then there are sprays, okay, such as Chloraseptic. That contain a numbing agent, which is phenol. Okay. So it numbs your throat a little bit, so the pain goes away. A good thing to do when you have something like this is to gargle with salt water. Okay. Because that can kill some bacteria. Okay, you cut down on the infection a little bit. But yeah, that is a serious sore throat right there. Okay. So let's take a look at pharyngitis.
I guarantee all of you out there have had some sort of pharyngitis before. It's a very common illness. And in fact, it's so common, it can be referred to as the common cold. But the common cold includes more than just pharyngitis. The common cold can spread to rhinitis, laryngitis, so on and so forth. And so there's all these names. There's these different names for a part of the body that is infected by either a virus or bacteria. Okay, so let's break this down. When we look at the word pharyngitis, we can break it down into a prefix and a suffix. The suffix is itis, and itis means inflammation or swelling. And pharynx refers to the pharynx, which is an anatomical word for essentially just the back of your throat. So when I break it down, it's inflammation and swelling in the back of the throat. Pharyngitis is a location of where the infection has spread to. Now, to fully understand where the inflammation is at, where the pharynx is at, I want to take a side view of the head so we can explore to something that we can't see just by opening the mouth. So here I'm drawing a human head, and I'll exaggerate a couple anatomical landmarks. So for example, this is the palate, and up here we have the nasal passage, which you'll notice connects to the back of the throat, and we have the mouth right here, and that opens into the oral cavity and down into the throat. Now, the pharynx is divided up into three parts, which are actually very intuitive based off of the anatomical location. So for example, right here is the nasal passage. So the top part of the pharynx is known as the nasopharynx. So this is the connection between the nasal passage and the pharynx, the nasopharynx. Right here we have the oral cavity. So this is called the oropharynx. And finally, the bottommost portion of the pharynx is known as the laryngopharynx. Laryngo refers to the larynx, which is also the voice box. So this is the area of the pharynx just above the voice box. So now we have a location to where pharyngitis is. And so viruses or bacteria that get back here and cause an infection cause irritation to the mucosa, or in other words, a wet surface that contacts the outside world. So this is the mucosa of the back of the throat. During an infection, the virus or the bacteria can cause damage to the mucosa, which leads to a variety of symptoms, such as dry throat, sore throat, which leads to difficulty swallowing, coughing, really anything that you can think of that has to do with swelling and inflammation of the back of the throat. And of course, these bugs can cause a fever too. Now notice I didn't put a runny nose or something like that. And that's because a runny nose is caused by inflammation of the nasal mucosa. But like I said, since these are just anatomical borders, infection can spread in either direction. And so you can have complications such as rhinitis, swelling of the nasal mucosa, or laryngitis, swelling of the larynx or the voice box. So if a bacteria or a virus is virulent enough, it can continue to spread and cause more infection. Now, if the infection becomes severe enough, it can cause inflammation of lymph nodes. Those are the glands in the neck. The lymph nodes are just centers where the immune system houses a lot of white blood cells. What happens is white blood cells in the throat, once they realize there's an infection, they'll travel to these lymph nodes and alert other white blood cells to become active. And this recruits the immune system to help fight off this infection. Now, who are the actors, the major culprits that cause pharyngitis? Well, most commonly, pharyngitis is viral. The viruses that usually cause pharyngitis are the viruses implicated in the common cold. And also other viruses that can cause pharyngitis are viruses that cause mononucleosis. Mononucleosis, also known as mono, or in layman's terms, the kissing disease. A lot of teenagers end up getting mono. And this is primarily caused by either EBV, which is Epstein-Barr virus, or CMV, which stands for cytomegalovirus. These two are very contagious viruses, and so it's easily passed in the saliva of teens. Now, while we're talking about it, Teens and kids are the population that are most commonly affected by pharyngitis. Adults get it less frequently. And that's because, well, one, young adults and children are still developing their immune system and have not been exposed to a lot of these bugs before. And two, especially in kids, they're notorious for grabbing things and touching each other and then touching themselves. And so this easily passes on infective material to the child. So viruses are a common cause of pharyngitis, but there's also bacteria. The most common bacteria in pharyngitis is known as Streptococcus pyogenes. This is also commonly referred to as group A strep, A being the specific type of Streptococcus. So there's group B, group C. Group A strep is specifically Streptococcus pyogenes. And even more commonly, this is called strep throat. Now, the bacteria is dangerous because it causes more serious infections, but also, if not treated with a full course of antibiotics, patients may develop some bizarre complications. And these complications may arise much later after the infection, maybe 2 weeks after the infection. Patients may have a fever. They may also experience joint pain in their elbows, knees, or really any joint. And more seriously, patients may develop heart problems. And this heart damage can cause issues for the rest of their life. Patients may also have some weird, strange shaking movements. They may do some weird dancing movements. They may develop a rash, high blood pressure, and very scary for a parent, they may also urinate blood. Now, these are different conditions. For example, the weird movements, the heart issues, and the joint problems are from rheumatic fever. And so this is why it's important to treat patients who have developed strep throat with a full course of antibiotics. It's to make sure that they don't develop some of these bizarre complications. Now, these complications can be very rare, but because it's unpredictable as to who will develop these complications, it's important for patients to take a full course of antibiotics if strep throat is suspected.
Okay. You can see here some of the bad actors. Okay, notice, right? You've got a couple of viral causes, right? Strep pyogenes, which we normally find in the mouth, is one of the common causes of cavities, right? Fusobacterium only is seen in people with suppressed immunity. Okay. And then viruses, again, they're going to come in and do what they do, right? They're mostly airborne, right? But you can have fomites, you can have direct contact. Okay. Virulence factors. Well, for the virus, it's the ability to attach and invade, right? That's how they do their thing. Converting tissues into virus factories, right? And the immune system comes in and tries to wipe them out. For strep pyogenes, okay, they've got M protein, they've got a capsule, right? So they're hard to phagocytose. They have super antigens and they can induce autoimmunity, right? So they can leave decoy behind and they can occupy the immune system with stuff that's not going to affect what they want to do, right? By leaving these little decoys for the immune system to chase. And then they can also turn on autoimmunity, where your immune system attacks your own tissue, right? And that's going to be a method similar to what the spirochete was doing, right? Leaving all this junk behind on cell membranes as it kind of works its way through tissues. And then the immune system gets distracted. Okay. So remember, when we're talking about virulence factors, we're talking about weapons, right? They're the weapons. Okay. For Fusobacterium, an opportunistic infection, you've got endotoxins and you've got leukotoxins. Leukotoxins wipe out white blood cells, okay? Wipe them out. Okay? And endotoxins are going to damage the other tissue types, okay? So treatment, right? Antibiotics. For both of these, okay? And we've got nothing for the viruses, okay? All we have are treating the symptoms, right? Taking away the pain and letting the virus run the course, all right? So there are no vaccines and no antivirals for this. Okay? Just don't have them yet. The cold is caused by something called rhinovirus, okay, which has the ability to mutate and change its appearance very easily. That's why there's so many serotypes. Serotype means different antibodies cling to the outside and indicate what's on the surface. Coronavirus, which we're well acquainted with these days, adenovirus, respiratory syncytial virus, which gets its name because it causes cells to fuse. When infected. You've got airborne, you've got indirect contact through fomites, okay, to spread it. Symptoms: sneezing, scratchy throat, runny nose, fever in children, okay? The runny nose and the scratchy throat are really kind of two of the same thing, right? What happens is you get something called postnasal drip. And that causes inflammation of the throat. Okay. So as it runs down the back of your throat, it burns. Okay. And it produces immune response that makes it even more inflamed. Okay. And in children sometimes get fever. Right. So there it is, right? Causative organisms, lots of different viruses. Okay. So airborne. Okay. Or fomites. Common vehicle, indirect contact. What are the virulence factors? What are the weapons? Well, the ability to attach, right? And cause the host response. Okay. It's the feeling bad is caused by inflammation. And the inflammation is an attempt to destroy virus. Okay. Prevent, big thing, wash your hands. Okay. And cover your mouth when you sneeze or cough. Okay. Sinusitis, basically the same idea. And sinusitis, instead of hitting the nose and the throat, we're actually getting back there in the paranasal sinuses, which are around the orbits, around the eyes. Okay. And other candidates besides virus, bacteria, fungi, and sometimes allergies. Okay. Which what they all have in common, right? Which makes the symptoms that we see, they all cause histamine release. Right? Which leads to inflammation. How do we treat? Antibiotics for the bacterials and antifungals for fungal, but for viruses, you just have to let it run its course. Okay. So here you can see, all right, the virulence factors for each one of these. I know they don't write anything down, but you just have to say really attachment. Okay. Attachment for all of these. Okay. Treatment, none, right? It's a virus, so no antivirals. And I'll put an asterisk there. Broad spectrum antibiotics for the bacteria and physical removal of the fungus or antifungals for the fungi, right? There is something that's been shown to have some effectiveness, which is zinc. Okay. Zinc interferes with attachment and boosts immunity. Okay. So it's a good idea to just kind of always take a zinc supplement, okay, if you don't get enough in your diet. And that can act as what we call a prophylactic defense against those types of sinusitis, okay? Including coronavirus, to be honest with you, okay? It can cut down on the likelihood of picking it up, okay? It won't guarantee that you'll be safe, but it'll help, okay? Zicam is a nice product to use. Otitis media is a viral or a bacterial infection that starts in the throat and works its way up the eustachian tube, which is connected to the middle ear. And then as the bacteria grow, the gas they create pushes out on the eardrum. And if we don't do anything about it, the eardrum will rupture. Okay. And this is incredibly painful. All right. And I can speak to that from extensive personal experience. When the eardrum grows back after a rupture, scar tissue develops and it reduces your hearing acuity. Okay. So you might be able to pass those old-fashioned sound tests they used to give where you would hear a tone, right? But it'll be difficult for you to distinguish words and language. Okay. You'll know that people are talking, but you won't know exactly what they're saying. You can see here that when the throat gets infected, if you get a positive pressure in the throat, you can force this material up the eustachian tube and into the middle ear, right? And as the bacteria grow, the gas they produce pushes out on the drum and eventually it'll pop. And then when it pops, all of this guck will just run out of the air and the pain will vanish. And then the drum will grow back. It'll have a big hairy scar, right, growing through the middle of it. So long-term treatment for this is something called myrintogomy tubes, where what they do is they put a tube in the ear that has a collar on either end. Okay, so there'll be a collar on this end. Okay, and then it'll come through the other side, right? And there'll be, they're not this long, but I'm just showing you. There'll be a smaller collar on this side, right? And the idea is that if the gas builds up, if you get an infection like this, then this is a pressure release valve, right? So the drum doesn't expand out and rupture as easily, okay? And eventually, as you grow older, the myrintogomy tubes will they'll pop out on this side of the ear, right? On the lateral side of the middle ear. And then you can just remove them with forceps, okay? And at that point, usually what happens is that the eustachian tube, which when you were younger was very short and straight, okay, becomes longer and twistier, right? And it's harder for the junk that's in your throat to get up into your middle ear. So you outgrow it, essentially, okay? Now the tubes will leave a scar, but it'll be a pinpoint scar. It won't be as bad as ripping the eardrum open. The treatments for the pain, there's something called Aralgin. Okay, it is a topical anesthetic. It's a numbing agent. Okay. You warm it up and you drop it on the drum and it numbs it for about 12 hours. And then you go and see the doctor and he'll deal with you. Okay. In the old days, if you'd go into the doctor's office and he would see this, what he would do is lance the drum. Meaning what? Well, he would take a long needle. Hold on. So what will happen is he'll take a long needle, put your head down on a counter or stabilize it. Okay. And let's do white needle. And he'll run the needle down into the drum and punch a tiny hole in it. Okay. And let that buildup behind the drum leak out. And then the pain goes away. Okay. And then that'll heal. All right. Lancing was better than letting it rip from the inside out because the opening would be smaller, but the ultimate fix was to get the tubes put in. Okay. Now today they don't do that as often. Today, what they prefer to do is antibiotics. To control the infection. Okay. And sometimes that works and sometimes it doesn't. Okay. So I've ruptured my eardrums 3 or 4 times on each side. That's one of the reasons that I have trouble distinguishing what people say sometimes. You can see here the causative agents, right? It's blue. So strep pneumoniae, Haemophilus influenzae, okay? And then there's viruses that can sort of set the stage for the bacterial infection. All right. What are the virulence factors? Well, there's that capsule again, which means it's tough to phagocytose. Hemolysin, right, which ruptures red blood cells. Okay. Here you've got a capsule and you've got Fimbriae for attachment. And for the viruses, there's attachment. How do we treat? There's antibiotics. Okay. Okay. Same here, right? And then for this, if it's a mixed infection, we throw an antibiotic in there to deal with the bacteria, right? We can't do anything about the virus, okay? And then hopefully either we wipe out the infection, right? Or we do something about the buildup, right? We pop the drum or we put in the tubes for a long-term treatment and deal with it that way. A good preventative, okay? There's a vaccine for this one, okay? There's a vaccine for this one, all right? There's nothing for these guys, all right? So if you're gonna swim, this is good advice for anybody, really. Put in earplugs, okay? And that keeps contaminated water from seeping under the drum and setting up an infection, or from you ingesting that water and having it infect your throat and get up into your ears, okay? And you can buy them at any drugstore. Diphtheria is caused by Corynebacterium diphtheriae. It is a gram-positive club-shaped bacteria, okay? So it's going to be purple and it's going to have a one end that's kind of swollen and the other end is smaller, okay? Transmitted by airborne and fomites. It has an exotoxin, okay? That it was actually brought into it by bacteriophage lysogeny. Remember, we talked about bacteria as these little parasites, bacteriophages, these little parasites of bacteria that can come in and integrate their DNA into the bacterial DNA and turn a harmless bacteria into one that causes disease. Okay, and that's what happens here. Preventative, there's a vaccine, okay, DTaP, which is highly recommended. Okay. And we treat with the antitoxin and these guys, which are antibiotics. So there we go, right? There's that diphtheria toxin. Okay. And there is our treatment, right? Antibiotics and antitoxins. Okay. And prevent, okay, get the vaccine. Okay. I'll talk about flu and pertussis and a few other diseases. So let's take a listen to flu.
So if you're watching this video, I'm pretty sure that at some point in your life or in the lives of someone you know, they've had the flu. Almost everybody is pretty familiar with how awful it feels to get sick with the flu. And when people talk about the flu, they kind of talk about it in two different ways. We're gonna get into both of those ways right now. So sometimes they'll talk about the illness or the symptoms they had when they had the flu. And other times they'll talk about the virus, the actual virus that causes the flu. So I'm going to actually break it down the same way. We're going to talk first about the illness, and then we're going to get into the virus. I'm going to draw a nice little line down the middle so we don't get lost in this conversation. So I can't help it, but anytime I hear that someone has the flu, I immediately get into this mode where I have a bunch of questions for them, and I really just want to kind of convince myself that when they say they have the flu, they really have the flu, and they don't have something else.
So the questions that pop in my head, the first one is usually, is it abrupt, or did it kind of start abruptly? I'm going to just write that. Was it abrupt? And, I might say, do you remember feeling well one evening and then waking up sick or something like that? Do you remember exactly kind of when it started? And most people with the flu can tell you within a day or two exactly when their illness started. Another clue that something is the flu is that it usually lasts for about 3 to 7 days. So if someone is saying, well, I got sick with the flu and then 4 months later, I started getting better, that's a very weird story. Usually it would be a lot quicker than that. So always think around 3 to 7 days. Of course, it could be a few extra days than that, especially when you're thinking about a symptom like the cough. But generally speaking, that's the time window. Then I really get into the symptoms themselves. I want to find out exactly what made them feel so sick. And there are 2 categories of symptoms. The first is respiratory symptoms. I want to know about respiratory symptoms. And secondly, I want to know about what I call constitutional symptoms. Constitutional symptoms. And this has nothing to do with the constitution, but it has to do with the body. So I'm thinking about symptoms that affect the entire body. So let me make a little bit of space on the canvas, and we'll first start out thinking about the respiratory side. So respiratory symptoms, let me draw out air coming into the body. Remember, air has 2 major paths into your body. It's going to come in through your nose, or it's going to come in through your mouth, right? And when it comes in, it's going to quickly join up. Remember, air in the nose is going to meet up with air in the mouth, and it's going to go down through the windpipe, or the trachea, we call it, and it's going to branch off into the right and left lung. So this is my right lung over here, and on the other side, we've got the left lung. And remember, the left lung is also going to be right next to the heart, so we've got to keep a little space for the heart. So these are the 2 lungs, and this is the air coming in. Now, if someone says that they have a stuffy nose, that's a really common one, right? They say they're congested, or sometimes they might say a runny nose, but any of these kinds of symptoms, you can think in your mind of this picture, and you can say, well, yep, this is right along the path that air is going to take on its way into the lungs. So this is part of the respiratory tract. Now, another symptom might be a sore throat, And here again, you can see that the air is actually going to be passing right through the throat on its way down into the lungs. And a really, really common symptom, you hear this all the time, is cough. And whenever people talk about cough, I just usually think about the lungs being involved there. So these symptoms, stuffy nose, sore throat, cough, you can think of this picture and really you can visualize the air going through, and somehow these parts are being involved. Now, exactly what's happening is that the virus is, of course, coming in, right? It's being breathed in. That's how we take in the flu virus. And as it hits these different areas, the cells are getting damaged. And that's what we experience as a stuffy nose or sore throat or cough. It's really damaged cells that are being affected by the virus. Now, moving on to the other side, the constitutional symptoms, these are symptoms that I want you to think of as affecting the whole body. So this is the whole body disease. Let's say these are the arms and the legs. These are symptoms like fever. Now, someone says they have fever. It's very hard to point to one exact part of the body that's affected, right? You might say, well, I feel feverish really all over. And if you're feeling feverish, this face would be very sad like that. So if you have symptoms like fevers, and with fevers, oftentimes you get chills as well. We're going to put that together. If you have fevers or chills, that would be a constitutional symptom. Another one would be something like body aches. If you are in bed because your whole body is aching, you wouldn't point to any one place. You'd say, well, it's just kind of all over. And so that would be another constitutional symptom. Another one that jumps to mind is fatigue. Kind of the same idea, where your whole body is affected here. So again, when someone tells me about flu, I'm thinking that they better have at least one of these respiratory symptoms and at least one of these constitutional symptoms. So I think of them in 2 categories, right? And I want at least one from each category. And they must have both if they're going to get me convinced that they have the flu. So scrolling up just a little bit, just to make sure we don't forget, it's got to be abrupt. It's going to happen over the course of 3 to 7 days. And they should have at least one respiratory symptom and at least one constitutional symptom. Now, this is good if I'm taking care of patients or I'm thinking about a clinical setting like the hospital or the emergency room. But what about if you're doing research? Well, it turns out that the Centers for Disease Control, they do a lot of research around influenza and flu. They have a definition that I want you to know about. Their definition, and you'll see this, is that the person has to have a sore throat or a cough, one or the other. I'll put a big or here. And they have to have fevers. So this is very similar to the definition I just gave you, but this is the definition they use when doing research or when actually presenting data. So it has to have these 2 things, right? Sore throat or a cough and fevers. And so this is the definition for influenza-like illness. Influenza-like illness. And the short way of saying all this is ILI. Influenza-like illness. So this again is a definition from the Centers for Disease Control. So if you ever hear ILI, at least now you know what they're considering as being someone that has ILI. So this brings up kind of an interesting question, and that's why I kind of started out by splitting things up between the illness and the virus. I want to go over to the virus side and just keep in the back of your mind this idea of ILI. Now on the virus side, let me just kind of sketch out very quickly in this green color what the influenza virus looks like. I'm going to label this influenza over here. So this is my influenza virus, and this little virus has got some RNA on the inside of it. So it's got RNA here. I'm going to draw out the RNA just so you can see it. I'm going to use 2 different colors. So let's use like a purple color here. And one important thing about this RNA is that it's broken up into little pieces the way I'm drawing it here. So it's got some purple chunks, and let's draw some yellow chunks of RNA as well. And this RNA, of course, is, as I said, genetic material. So it's going to be coding for proteins. So you've got some proteins, and let's say that you've got some proteins out here on the surface. And you can imagine that those yellow proteins come from one of those yellow RNA segments. And you've also got some purple proteins over here. So purple proteins. I'm going to draw out some purple proteins here for you. So let's say that the purple protein, we can call that H, and the yellow protein, we can call that N. So what you're getting here is that you're seeing a couple of the important parts of influenza virus. I just want you to start getting familiar with the fact that it has, RNA on the inside that's broken up into chunks, that it's got some surface proteins on the outside, and a couple of those important ones, we call them H and N for short. And I'll tell you more about them in a future video. So this is influenza virus. And now the question is, if you have someone, let's say I've got a friend or a family member who tells me that they had an abrupt illness that was 6 days, and they had fevers and a cough. Well, it sounds like, based on what I said, that this meets, of course, the CDC definition for influenza-like illness. And so if I tested them, let's say I actually, checked their nose with a little nose swab and did a test, you would expect that I would actually find influenza there. And most of the time, I would actually find influenza there, but not always. And this is actually an important concept, that there are actually, believe it or not, some of these little copycat viruses. going to draw a couple copycat viruses here for you. I'm going to write out 2 of them. There are actually more than 2, but we're just going to talk about 2 of them. And I'm not going to draw them accurately. This is just kind of a visual representation, just to kind of show you what they are and write up their names. One is called rhinovirus. Rhinovirus. And you may be aware that rhino means nose, and actually rhinovirus loves to infect the nose. And that's actually why it's called rhinovirus. And another copycat virus, I'm going to draw it looking a little different, maybe sideways looking things. Here this guy, this is RSV. RSV. And the full name of RSV is respiratory, so you know it affects the lungs, syncytial virus, respiratory syncytial virus. And we'll talk about that another time as well. But the idea here, guys, is that these copycat viruses, this is interesting, they can actually sometimes fool us into thinking that we're dealing with influenza. Because some of the symptoms you get with rhinovirus and that you get with RSV end up being pretty similar to the symptoms you get with the flu. And so as a result, we have to have some way of telling them apart. And that's why actually you may have heard of the term the cold. Let me actually bring this down and actually show you now the cold and the flu side by side and how to kind of distinguish between the two. So when you have, let's say, the flu, we said that usually you would have some respiratory symptoms, check, and you'd have some constitutional symptoms, check. But if you have the cold, kind of the common cold we call it, then you generally only have respiratory symptoms. You don't typically have fevers and chills and body aches and fatigue. You don't usually have that stuff with the cold. So that's kind of the easy and quick way to distinguish between the flu and the cold. And those are the questions I always ask, patients of mine. I say, well, did you have body aches or fatigue? And if the answers to all those kinds of questions are no, I'm thinking, aha, this person has the cold. But of course, this isn't exact, right? This isn't perfect. And that once in a while, people will actually fool you. And they will actually have one of these copycat viruses, the rhinovirus or RSV or adenovirus, or many other ones. And they'll actually have influenza-like illness. They'll actually have sore throat and fevers and body aches. So this is important to know that every single time we clinically think someone has flu illness doesn't necessarily mean that they have the influenza virus.
Whooping cough or pertussis is caused by Bordetella pertussis, the bacteria, spread airborne, incubation phase between 3 days and 3 weeks. The catarrhal stage is going to show runny nose for about 2 weeks. The paroxysmal stage, severe coughing, okay, with that high-pitched whoop in the cough. Recovery, you're susceptible to respiratory infections because the pertussis has sort of occupied your immunity and has tenderized the tissue. We prevent with the vaccine, and there's an antibiotic treatment for those that have the disease in order to cut down on the growth of the bacteria. The vaccine is not lifelong immunity because, again, of mutation, right? A lot of outbreaks today are because of lack of vaccination and lack of a booster shot, right? A lot of these vaccines that wear off, you need a booster in order to remind the immune system that you have this potential vulnerability, right? So here you can see, again, with, whoops, sorry. Okay, the bacteria, right? Airborne or spread. Okay. What are the weapons? Okay. Fembrile hemagglutinin, okay, meaning what? Causes RBCs to clump. And rupture. Okay. Pertussis toxin, and then endotoxin, right? And there's a cytotoxin as well, okay? All of which are going to be damaging to the tissues that they come into contact with. So what's the treatment? The antibiotic. Okay. And then prevention, there is a vaccine. Okay. Respiratory syncytial virus is, again, spread airborne or by fomite. You get a lot of colds and flu and respiratory infections in the wintertime. And the reason for that is because you're indoors more often. Okay. Preemies and children 6 months or younger are susceptible And the reason for that is their immune system isn't developed. Okay. What are the weapons? Formation of these giant cells. Okay, that's what damages the tissue. They fuse together, so you get these. These are multinucleate cells. Okay, and that means they can't function very well. Plus, they make more virus. Prevention: antibody for high-risk children. Okay, that's just temporary. So here you can see, right? It's a virus, airborne spread. Okay, it causes cell fusion. Okay, and then treatment. There is an antiviral, ribavirin, but mostly we just wait for it to resolve. Okay. Okay. Next, we'll talk about TB and TB testing, okay, and pneumonia. So let's look at TB.
So I've drawn out for you a mother over here, a mom, and her son on the right. And it turns out that mom has tuberculosis. Let's assume that. And sometimes when you see tuberculosis written out the way I'm writing it out, you'll actually see them shorthanded or kind of use the quick way of saying it, which is 2 letters, which is TB. So let's say mom has TB. Now, this is actually a diagnosis, right? This is a description of her illness. This is telling us what she actually has, what she's sick with. But we have to remember that tuberculosis is actually caused by an organism, right? It's actually caused by a bacteria, it turns out. And this bacteria has the name Myco, M-Y-C-O, bacterium, Mycobacterium tuberculosis. So this is actually a very easy one to remember because tuberculosis is right here in the name. Now, I should point out, Mycobacterium tuberculosis is actually not the only cause of tuberculosis. Turns out there are a few other kind of related Mycobacterium, using this word myco, that also cause TB. But this one, the one I wrote out for you, this is definitely the most common around the world, and that's the one I'm going to focus on. And in fact, this myco, M-Y-C-O, this is actually Greek for the term fungus. And the reason that this is here actually kind of tells us a little bit about how this bacteria grows, because it grows really slowly like a fungus. And that's actually the reason that they use the term myco. But nevertheless, it is a bacteria. And so if we're going to put a little bracket around the diagnosis, I also want to put a little bracket around this part to kind of distinguish the two. So now you can see very clearly TB, the diagnosis, is caused by a bacteria. So now let's talk about how mom, who we said already is sick with TB, I'm going to actually just sketch out what her lungs might look like, assuming that the TB is in her lungs. This is actually the most common place we think of with TB, but not the only place. But let's say that she's got little red, I'm going to draw it in red, bacteria here in her lungs, causing her to be very, very sick with tuberculosis. You know, she could spread it to her son. But what are the different ways that she might spread it? What are the most common ways? Well, let me sketch out a few possibilities, and we're going to go over whether these possibilities are very likely or unlikely to be a way for her to spread disease to her son. So let's say first, they're sharing this delicious pizza I'm drawing here. They're, let's say they're very into pizza and they, like to share food. And they both, chow down on this little pizza here. That's one way they might potentially, you might think of as a way to spread it. Maybe they're even sharing a drink. Maybe there's a drink here, and this drink, they're sharing again. You might also think about, what's going on in their house. Maybe they're opening and closing doors, and maybe they're touching doorknobs. There's another way, right? Maybe they're touching stuff in common. Maybe, she says to him, hey, here, grab these keys. And she's been holding the keys all day, and then she gives him the keys and he holds the keys. There's another way, right? Maybe the TB can touch objects in the environment, like a doorknob or a key. And then there's the most obvious way you might be thinking. Maybe she's coughing. Maybe she has a loud cough. Maybe she's coughing all day, and some of these bacteria get in the air, right? So that's another way that you might imagine that the bacteria could spread from her to her son. So different ways, right? Now, of these ways, I'm going to actually label this one over here. Let's say this is through the air. Which are the most common ways to be really concerned about TB spreading? And I'm actually going to just put it in green so it really sticks out. The most common way is what we call person to person through the air. So in this case, the first person would be mom because she's sick, and it's going to go through the air down to her son. And these other ways, for example, food and drink, that's really not so common. That's really, really unlikely to be a way of spreading TB. And in fact, even this down here is really not likely either. So the idea of getting TB by sharing food and drink or touching objects in your environment like the keys or the doorknob or things like that, that's really not how TB spreads usually. Usually it's spread through the air. And one person, the sick person, is usually coughing a lot, and then the other person might breathe it in. So let me make a little bit of space on this canvas, and let's talk about what happens next. I'm going to draw one alveolus here, and I'm going to copy it a few times just so you can see a few different possibilities in terms of what might happen. And these represent the sun's alveoli. These are the sun's alveoli. Of course, these are the tiny little air sacs at the very ends of the bronchial tree, right? So let me make a few copies of this. So there we go. We have 4 possibilities, right? Possibility 1, 2, 3, and 4. I'm basically going to go through different scenarios, different things that might happen when mom coughs. So maybe she coughs, and the first possibility could be that the bacteria, they just don't get far enough. They don't actually make it to the son, and he never ends up breathing them in. So if this was the case, there would be no bacteria in his alveoli. Of course, his lungs are nice and clean. Let me draw his lungs in. They look nice and clean with no bacteria, and he's feeling great, right? This is our son over here feeling really good. And we would say basically in this case, in scenario 1, he's healthy because the bacteria never even got to his lungs. All right, now scenario 2, let me actually erase a couple of these. Let's say that the cough actually was very strong and he was close by, and he ended up breathing some of these in through his nose or his mouth, and they went down into his lungs, right? So that's another possibility. Once the bacteria get there, let me actually draw them on this little alveoli. In possibility number 2, they might actually get picked up by little immune cells. So he has little cells that are patrolling the lungs, making sure they're nice and clean and healthy. And these little immune cells, I'm going to label them over here. These are macrophages. Macrophages, actually, this literally means big eater because phage means to eat. And so these immune cells, they might kind of come by and gobble up these bacteria and take them in and destroy them. That's another possibility. So that would be possibility number 2. So here the bacteria are gone. Now let's play it out again. Let's say scenario 3, also you have a couple of bacteria in here, and just as before, you get a couple of immune cells that come by and they swallow up these little bacteria. These are the macrophages I'm drawing, swallowing up the bacteria. But let's say that unfortunately in scenario 3, now these macrophages, for whatever reason, cannot destroy the bacteria. The bacteria are still living, and that's why I draw them here as little red dots. They're still living, still there. And now let me draw the 4th scenario, which is, again, let's say a couple of bacteria get in, and let's say that, the immune cells, again, they kind of get alerted, and they kind of come by and pick up one of them. Maybe this immune cell is trying to go after this other one. Maybe he's really close by. But here the key difference is that these bacteria are actually multiplying. So I'm actually going to draw lots of them. These bacteria are multiplying, and they're filling up this space. So this space is filling up with little tiny red bacteria. So the key difference here is that these ones are multiplying. And we didn't really talk about the other scenarios having bacteria that are multiplying, but now that's the key new thing here. And in this scenario, we call it active because you're actually seeing the bacteria thriving. We call this active TB infection, active TB infection. And that goes back to kind of what we would label the other scenarios, these ones. And these ones together, we actually call both of them latent TB infection, latent TB infection. And the reason I'm putting them together is because it's very hard clinically to distinguish scenario 2 from scenario 3, because in both cases, the immune system has previous experience with the TB bacteria. It's seen the TB bacteria. And in both cases, you're not seeing lots and lots of bacteria dividing or multiplying. So we lump these together and call them both latent TB infection. The real key, and this is kind of the take home that I want to point out, is that there is a difference then between healthy, someone that's really never seen TB in their life before, latent, where you have seen TB previously, but you don't have any bacteria that are multiplying, and active TB infection, where you have lots and lots of TB bacteria that are multiplying. Let me make just a little bit more space then. I'm going to focus now on just this final one, this multiplying active TB infection situation. So if, let's say, our son in this case gets tuberculosis from mother or from mom, and let's say unfortunately he has an active TB infection, what are some clues to tell us that he has an active infection? So if I'm trying to figure out if somebody has TB, I always think about two key things. What are their symptoms? What are they sick with? That's the first thing. And then how long is it going on for? I'm going to call that duration. And these two offer really, really helpful clues to figuring out if someone has TB. And with symptoms, I'm going to break it up into two categories. The first is constitutional. Constitutional. And this is constitutional symptoms. And this is kind of things that affect the whole body. The whole body. So I'm just going to put a little bracket on the entire body to remind us of that. And this could be things like, fevers or chills. You can't say, you can't really point to one part of your body and say, this is the part that's having fevers and chills. You say, well, just generally, I feel awful. This could be things like night sweats. If you wake up and your t-shirt is all wet, you might say, well, those are night sweats. Another example of a constitutional symptom is weight loss. In particular, when you're not trying to lose weight, especially because you're maybe not eating as much or you're vomiting or anything like that. And now the other category is lower respiratory tract. I'm going to say respiratory, I'm going to abridge it to just RESP tract. And this, if I want to draw it in, would basically be kind of the part I've drawn in blue here. So going down from your voice box all the way to the alveoli. So this would be your lower respiratory tract. And you can think about what sort of symptoms you might have there, right? So it could be things like coughing, right? That would be coming from the lungs. If you're coughing very hard, you might have some blood or some little streaks of red that are blood in your sputum. So it could be bloody sputum. That would be another one. And the sputum, of course, is just the mucus stuff that you kind of cough up. And a lot of people that are coughing this much, they might have trouble breathing or, chest pain, anything like that. So these are kind of just some examples of lower respiratory tract symptoms. And so I always think in my head, okay, are they having constitutional symptoms? If so, I put a check there. Are they having some lower respiratory tract symptoms? If so, I put a check there. And then how long is it going for? And usually with things like active TB infection, I'm thinking it's got to be usually more than 3 weeks. So more than 3 weeks. And this is, again, focusing on TB of the lungs or the pleura, which is the space around the lungs. Generally, the symptoms have gone on for a little while. So these then become very helpful clues to figuring out if someone actually has active TB infection.
Our next one is pneumonia. Hold on.
So when you hear the term pneumonia, I think that most of us think about lung infection, but not much else besides that. And pneumonia really is a little bit more than just a lung infection, really in relation to where it is. So if we're looking at this image here, I want to focus on just the lungs that I've drawn out. So we know that we have a right and a left lung. And in our right lung, I'm just going to draw out some lobes here. We know that we've got 3 lobes in our right lung. So we have an upper, a middle, and a lower. And in our left, we've got 2. And we know that we have an airway, so our main airway. Now, don't focus on this yellow line yet, just focus on our main airway. So we know we breathe in air, and that air is going to travel down through these smaller branches, these branches that branch off. And at the end of our airway, we have these little grape-like sacs. So I'm just going to draw a couple just right here so we can see. And these little grape-like sacs are actually air sacs, and we call those alveoli. The alveoli is really important because that's where the gas exchange happens. This is where ultimately the oxygen is going to end up and where we'll pick up carbon dioxide to exhale out. So why is this important? Well, when we talk about pneumonia, the infection is actually in these air sacs. So what I'm doing is I'm drawing these sacs as if we could blow them up millions and millions of times because they're actually very, very tiny. We have millions of them everywhere at the end of our airways. So if we could blow them up, they'd look something like this. Now, right underneath it, I'm going to just keep drawing the kind of structure that we can expect that we'll see. So we have just air sacs that I've drawn. Right underneath our air sacs, we have tiny blood vessels that run beneath them and all around them. And in between our air sacs, we just have some lung tissue. So I'll just make that this brown color, make some lines to represent our lung tissue. So when we say that a person has pneumonia, the pneumonia infection is actually inside of these air sacs. And this is where the pneumonia is. Now, anytime that there's an infection or injury in the body's response at that site is to cause inflammation. So that means that the tissue, that alveolar tissue, is going to inflame and it's going to leak fluid. Well, that fluid I'm making green and I'm filling up the alveoli with this green fluid to represent the infection. It's going to leak out infected fluid into this air sac. Now, why is this a problem? Well, remember, we're breathing in air, right? So let's come over here and make this blue. So let's say that here's my air. I'm just going to travel down some blue air and I'm breathing that down. I'm breathing that down. I'm breathing that down. And it's coming all the way down to our alveoli because this is where I want to drop off the oxygen so I can breathe and ultimately get the oxygen into my capillaries, right? Because that's what we need. The problem is that I kind of have this block. I have this infectious fluid that's blocking that absorption of oxygen, and it's going to block the exhalation of carbon dioxide as well. And that's a problem with pneumonia. It's taking up airspace. So as you can see, if this person had pneumonia, and let's go ahead and even draw it on our smaller grid. Let's shade in some green into our alveoli here. If this person had pneumonia, what will we expect to see in them? Well, we can see that we have our air sacs being occupied with this infectious material. So think about how that's going to affect their breathing. One of the things that we're going to see is dyspnea, which really is a fancy term for difficulty breathing. The problem that we're having really is shortness of breath. So I'll just put short of breath. And that's because looking at our image, we see that we're not able to have that gas exchange. We can't get that oxygen into our space because it's being blocked by something else. They're going to be experiencing chest pain as well. And we know that's secondary to the inflammation that's happening at the alveolar level. And we have pain receptors in our chest, so we're going to feel that. How about cough? Thinking about all that fluid in our air sacs, what do you think the body's going to try to do? It's definitely going to try to cough, right? That's the mechanism that our body has. It's going to try to cough to squeeze out and force out that fluid out of the airways to clear it so we have room to breathe. And we keep talking about infection. So with an infection, you can expect to see a fever. That could be low grade or that could be high grade. So how does this happen? How do we get a pneumonia infection? Well, there's really two ways. So it can be from organisms, right? Just that we get out in the community, or it can be from other ways that might not fit into that category. So for the first one, I want you to think about organisms. So I'm going to come over to the shoulder and I'm going to draw in a circle that's going to represent my bacteria. Then I'm going to draw in a little viral illustration to represent a virus. Bacteria and viruses are certainly the most common causes of pneumonia. The good thing is that we have vaccines to combat two of the biggest culprits, which would be our Streptococcus pneumoniae, that's our bacteria, and the flu virus. These are big offenders that cause pneumonia infections. Now, when we pick up an organism like a bacteria or a virus, and we can also get funguses and mycoplasmas as well, we call this community acquired. I'm going to write that here, community acquired pneumonia. And when I say pick up, I mean just in our everyday activities. Community, you're thinking about people. So think about work or school, or you're out doing leisure activities. Because you're surrounded by people, and if you picked up an organism from somebody that was ill, we would call that community acquired pneumonia. Now, just as we have air, we know that the transmission of air into our lungs, if we get a bacteria that enters our airway, it's going to travel down and it's going to cause this infection. Now, we said we would talk about other ways. Something that falls under our other way would be ventilator assisted or ventilator acquired pneumonia. So I'm going to write that here, ventilator acquired pneumonia. Any better? Pneumonia. So someone's on a ventilator, we know that they're connected to a tube that's delivering oxygen to them. So let's come over here and actually just erase away my little air symbol that I made earlier. That way we can make room for our tube. I'm just going to put it down to here. Now in this orange color, let's draw in this tube. So we know the tube is inserted through the mouth or through the nose, and then it's guided down into the airway. And it'll end about here. So this tube is going to be delivering oxygen to this patient. Well, on the outside, this tube is actually connected to a device. And so I'm going to write O2 here because we know that's doing the work of breathing for them. Well, what's the problem with this? We know that because it's a direct route from the outside to the inside, that things like bacteria, viruses, other harmful organisms can actually get inside of the tube, can grow and cause a pneumonia infection. Another way that we can get pneumonia that doesn't quite fit under our community acquired or ventilator acquired would be aspiration. Now, aspiration means to breathe in. And in this case, we would be breathing in something into the lungs that shouldn't be there. So let's get rid of our tube so we can visualize aspiration. And I want you to really think about patients that are at greatest risk for this, like patients that have been experiencing vomiting, for instance. We can aspirate vomit into our lungs. Now, if you take a look at that yellow object that I said don't focus on earlier, take a look at that now and see how it's moving. This yellow object is our epiglottis. Our epiglottis really directs traffic. We know that we have one main tube, but this tube actually is split into two. One route's going to go to the stomach and one route's going to go to our lungs. So let me move that open for a second and let's see the difference. So in blue here, this is going to be our direct route to our lungs. And then in green here, this would be our route to our stomach. Let's all just keep that going down like it's going to our stomach. Well, in the event that our epiglottis is open, that means that something can get inside of our airway. So in this case, we talked about vomit. If somebody was vomiting and our epiglottis is open, we can actually aspirate the vomit into our lungs. And because our lungs are a sterile environment, anything that gets in there that's carrying bacteria is a danger to us because it can make us very sick. The same thing can happen with somebody that is eating and accidentally aspirates food into their lungs.
Okay. So we'll get to the last slide on respiratory, and what you can see here. Let's do this in share. New share. Yeah. Again, notice, right, that a lot of these are viral. Okay. Everything in green, viral. Okay. You've got them here, you've got them here, you've got them here. Okay. And when they say viruses, they've got them here. You've got many, many, many different varieties of viruses. Okay. Bacteria account for a few of them. Okay. And fungi, just a very tiny amount. Okay. So again, a good summary slide for this particular chapter for you to star and to study from. Okay. So what I want to do now is do a little bit of review for the lab practical. Okay. So let me pull that up for you. Here we want. So, we want. This. There. Okay. Hmm. So Okay. Yeah, that'll work. That'll work. Okay. So shoot this up here. Sure. For now. This. Here. Here. Okay. All right. So I just want to go over a few things, right? So we'll talk about how this is going to be laid out, right? Then we're going to talk about the stuff that we're going to cover. So what specifically am I going to draw on for the lab practical? Okay, and let's do. I'm going to do oxygen classification, control chemicals and antibiotics, media types, okay, plate counts and staining, okay, and then we'll throw biosafety in. Okay, we can skip this and this, right? Because we didn't get really too in depth with that. Right? So, so biosafety. If we were in a real lab, all right. I know we're not a real lab, but if we were in a real lab, no food or drink, no cosmetics, no open-toed shoes, lab doors closed, no mouth pipetting. Okay. And the reason for these is to reduce exposure. To pathogens and toxic chemicals. Okay. If you do that in the lab, there's potential you could get it on you or in you. Okay. Take care when handling hazardous material. That's just common sense. Wear PPE at all times. So what is PPE? Lab coat, gloves, mask, no open-toed shoes, okay, and long pants, dresses, or leggings. Again, to reduce exposure. Okay. Okay. You got to dispose of everything that touched bacteria or virus into a biohazard bag. Okay. The biohazard symbol okay, is basically 3 circles like this. Okay. And they're usually in blue All right. And then the word biohazard will be above and below, above or below the symbol. Okay. All sharps in glass in sharps containers. Okay. Sharps containers are usually red, plastic, with lid. And usually has biohazard symbol on it. All right. Glass is usually in glass waste. Okay. Glass waste containers are generally, this would be non-infectious glass waste, generally blue and white. Boxes with plastic liner. And it'll say glass on it. Okay. For infectious glass, okay, you put it in the sharps container. You would tell somebody if there was an accident or a spill, and you would tell them about medical conditions that you have. Okay. Wash your hands before you start work. Disinfect your lab table so to cut down on contamination. And exposure. Goggles are part of your personal protective equipment, okay, along with masks and everything else. There's an apron or lab coat and gloves, okay, and then we would add mask. Okay. When you're done, right, dispose of your waste in the appropriate container, disinfect the table, remove gloves inside out, and put in the biohazard waste, right? Look for that symbol. Okay. Remove apron inside out and store in your drawer, or if it's a disposable apron, ditch it. Okay. And where should you pitch it? Biohazardous waste. Okay. If it's a lab coat, all right, you keep it in the lab. Store your goggles. There'll either be a personal drawer for you, or there'll be a common place for the goggles to be where they get hit with UV to disinfect them. All right. And of course, wash your hands before you leave. Right. And what's this designed to do? Keep you from exposure. Okay. And keep you from exposing others. Okay. Some stains that we've talked about, right? A simple stain will stain the cells, but not the background, while a negative stain will stain the background, but not the cells, okay? Live bacteria can be used here. Differential stain stains on certain types of cells based on properties, such as the Gram stain, right? Gram positive, Gram negative, Gram positive, purple, Gram negative, pink. one example of a differential stain. There are others. A basic stain will be attracted to a negative cell wall, and an acidic stain will be attracted to a positive structure and repelled by a negative cell wall. Okay. And that's because acidic stains have a negative charge and basic stains have a positive charge. Okay. In a differential stain, different types of bacteria will have different colors. The primary stain is the first stain used and will stain everything and then is removed by a treatment. Okay. The mordant improves the ability of the primary to bind. The decolorizer removes primary from some cells, but not others. And then the counter stain is a second dye that stains the decolorized cells, right? So see an example, right? You spread a culture of bacteria from a liquid culture over a slide. You can let it air dry, okay? Or you can heat fix it, all right? And then you can do a differential stain, like a Gram stain here, okay? Remember that a Gram stain begins with crystal violet as the primary, which would stain everything. Iodine, which will fix the primary stain to the cells that are going to cling to it, but not the other cells. Decolorizer in this case is ethanol. So that's going to remove the crystal violet from the Gram negative cells. And then the counter stain is the safranin, all right, which is going to stain everything, but the Gram positives are still going to look purple, okay? And so you can see here, right, that the Gram positives end up with the purple stain, the Gram negatives end up with the pink stain, okay? You can see here the example with Staphylococcus. Oh, geez. That's okay. Gram positives. Okay. And Gram negatives. Okay. So some examples, right? Gram positives, Bacillus megaterium, Stabsilosis, Gram negatives, E. coli. Okay, we've got other examples as well. With a capsule stain, all right, there's no heat fixing step, right? And what you're doing here is the capsule won't hold any stain. But everything else stains. Okay. So you can see here, right? If there's no capsule, what happens? The crystal violet will stain the bacteria and the copper sulfate won't have any effect on the color. Okay. That's the decolorizer and counter stain. Here, if there's a capsule, the copper sulfate will decolorize the capsule. All right. But the cytoplasm in the background will be purple. All right, and you can see here some examples of capsule stained bacteria. Right? Okay. So these are some examples. Okay, Enterobacter, Klebsiella pneumoniae, Serratia marcescens. Okay, all examples of bacteria with capsules. Right. There are others. Acid fast stain. All right. In an acid fast stain, you treat with the primary. Okay. Acid alcohol is the decolorizer. So the non-acid fasts will clear. And then methylene blue is the counter stain. All right. And so non-acid fast will appear blue and acid fast will appear red. Okay. So you can see here an example, right? Non-acid fast. Okay. And then you can see here, acid fast. Okay. An example, Mycobacterium, okay, but there are others, okay. And what I'll do on the practical is I'll tell you what I'm looking for. Like I'll show you a slide, all right, and I'll tell you how it was stained, okay, and then I'll indicate on the slide some cells, and I'll ask you whether they're acid fast or non-acid fast, or whether they're gram positive or gram negative, and then I'll ask you about their shape, right? Are they cocci or they're spirochete? Are they rods? Okay, and do they occur in clusters, in chains, in pairs? Okay, so that's how you ID them. All right. Endospore stain. All right. The primary is malachite green. Right. Everything stains green. Water's a decolorizer. Right. And then safranin is the counter stain. And so what happens is the endospore is going to stay green and the rest of the cell is going to be pink. All right. So this is endospore positive. This is endospore negative, right? And so you can see if you look at the arrows, they're indicating cells that have endospores in them, okay? And then there's plenty of cells in there that don't, okay? An example of a spore former is Bacillus megaterium, okay? But there are others, many others. Four-way plate streak, we'll skip because we didn't touch on that. Okay. All right. Plate counts, all right? So the idea here, all right, is that you get to a plate on a dilution series. Remember that when you're doing this, you have a series of plates with media in them, right? And then you go from a liquid culture in a test tube. Okay, so we'll make a good color for bacteria. Make it magenta. Okay, so there's bacteria here in this sample, right? Okay, and so you would take out of this a certain amount of sample, let's say, 20 microliters. Okay, you would plate that, right? And then you would take 20 microliters of a 1 to 10 dilution. So what you would do is you would have another tube, right? You have another tube. You'd have media in it, liquid media. And you would take 20 microliters of that straight culture, and you would add it to 180 microliters of media. Okay. And that's a 1 to 10 dilution. All right. Then you could make another dilution, a 1 to 100 dilution. Okay. Would have 180 in here. All right. And then you would take 20 from this tube and put it in. Right. And you could continue that for however many tubes you want. So you could say this is the straight, this is the 1 to 10, this is the 1 to 100, and this is the 1 to 1,000. Okay. You would plate those. Okay. And that would represent the amount of bacteria that's in 20 microliters of each of those samples. Okay. Then you'd let them grow. Okay. You'd let them grow. Right. So you're going to plate, 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 plate. Okay. Same volume, but of dilutions here. Right. You're going to grow them overnight. 37, because it's body temperature. And then when you take the plates out, what are you going to see? Well, you're going to see colonies that have grown up that represent a single bacterial cell. So on the straight plate, you might see a whole bunch. In fact, so many that almost the whole plate may be covered. Okay. Okay. And then here you'd see tenfold less. And here maybe tenfold less than that. And here maybe tenfold less than that. Just a single colony there. All right. And so what you're going to do is you're going to pick a plate that has a number of colonies that you can easily count just by hand. Right. So I would probably select this plate. I would count it. Okay. I would put the number of colonies here. All right. And then I would multiply that by 1 over the total dilution plated. All right. So the total dilution plated was a 1 to 100 in this case. Right. That's this plate. Okay. So 1 to 100. Okay. And I would do that multiplication and I would get the number of colonies in 20 microliters of the original sample. Right. And so that's how you do a plate count. And that's also part of how you do what we call a growth curve. Is that you take samples at different times during the incubation of your culture and you plate them out and then you look at them after overnight growth, and that allows you to determine when the bacteria hit their peak, when they plateaued, and then when they started to decline. Okay. And then that's just for doing it from a urine specimen. Don't worry about that. Not worried about that. Okay. Now, media types. Okay. Nutrient agar. Okay. Culture of non-fastidious organisms, meaning bacteria that grow easily. Okay. So some examples would be stuff like Luria broth media, okay, or nutrient agar. Okay, which are a couple of examples. Agar broth is a selective media, okay, it has an acidic pH, and it's used to grow fungi, right? Yeast and mold and not bacteria. Okay? That's a special media. This would be selective. Okay? Brain heart agar. Okay. It's used to determine oxygen classification. So it's similar to something called thioglycolate broth. Okay. So you can see here different types of oxygen requirements mean different growth patterns. Okay. So they grow at different levels. The deeper you are in the broth, the less oxygen, right? So low oxygen here. Okay. And high oxygen here. Here's sodium thioglycolate. You've got a couple of labs on that. Okay. One that is up on Connect, and you've got, I think that's the only one. It's the only one I sent you. And then the idea here again is that you can tell the oxygen requirements, right? Low oxygen at the bottom and high oxygen at the top. And that allows you to tell what the oxygen requirements are. All right. So if it's aerobic, it'll look like that. If it's facultative, look like that. If it's microaerophilic, look like that. And if it's anaerobic, look like that. See, it's not growing at the top. No growth. Okay. Mannitol salt agar is both selective and differential. Okay, meaning what? Only salt tolerant bacteria will grow. Differential, meaning that different types of salt tolerant bacteria will look different. Okay. So it's got a lot of salt in it, just high salt. Okay. It has mannitol in it, which is for fermentation. Okay, this is our differential food source, right? And then phenol red is a pH indicator. So this turns yellow with acids. Okay. The idea is that if the bacteria can ferment the mannitol, the area around it will turn yellow, right? So you know what type of salt tolerant bacteria it is. Okay. So examples are you can grow different staph species on this, and you can distinguish between different staph species, right? There's Staph epidermis, there's Staph aureus, right? Aureus is a pathogen. Okay. And epidermis is non-pathogenic. Blood agar is differential media. Okay, so that means different bacteria will look different on the plate. Okay. It has sheep blood in it, and so this provides nutrients for bacteria that can do hemolysis, meaning what? Rupture RBCs. We can use it to culture fastidious organisms, meaning what? Picky. Okay. And we can use it to distinguish between different types of hemolysis patterns, right? There's alpha hemolysis, beta hemolysis, and gamma hemolysis. Okay. And depending on what type, you either have a pathogen or you don't. So you can see examples here, right? There's beta, that's usually a pathogen. Okay. There's alpha and gamma, And these are usually non-pathogenic. Okay. All right, chocolate agar. Boiled sheep blood, again, for fastidious growth, all right, such as Neisseria. It's used to distinguish Neisseria species using something called the oxidase test, okay? So you can see here the growth of the species on the chocolate agar, and then you can see with a chemical test which ones are oxidase positive, okay? So this is a separate media, okay? This is for growth. Okay, and this is for differentiation. Which would be telling species apart. Mueller-Hinton agar has tellurite in it, allows us to distinguish Corynebacterium species based on the ability to act on tellurium by reducing it, turning it black. Okay, so the black colonies indicate certain types of Corynebacteria. Okay, differential stain, meaning different bacteria look different. We don't need to worry about that one. That's pretty exotic. McConkey, though, that's a big one. All right. It's both selective and differential, right? Has crystal violet, bile salts, lactose, and neutral red, right? So what does it do? It selects for gram negatives, okay? And then it distinguishes, differentiates between gram negatives that can ferment lactose, okay? So the gram negatives that can ferment lactose fermenters, turn the agar yellow. Okay. Those that don't, do not. It stays red. EMB agar. Okay. There's eosin in it. Okay. There's methylene blue, and there's lactose. Okay. Again, to distinguish between gram negative species and to determine their ability to ferment lactose, right? So if you can ferment lactose, what happens is that you will appear a different color, right? Than if you can't. That's why it's differential, right? It's selective because only gram negatives grow. Okay. Okay, we can skip Snyder temperature classification. We can skip. Okay. Oxygen classification. All right. You want sodium thioglycolate, right? That's the big one. That's the one we did. And you can see the differences, right? Obligate anaerobe, right? Obligate aerobe. See how he's up towards the top there? Okay, he doesn't like the low oxygen. Aerotolerant, okay, and facultative, which look pretty similar, to be honest with you, okay? But the point is, with the facultative, they can switch off, right? They can do anything they like, so they can grow all over, all right? Aerotolerant, same deal, okay? But these guys have to have oxygen, okay? This is high oxygen. And these guys don't like oxygen. This is low oxygen. Okay, control with chemicals and antibiotics. The idea here again, this is Kirby Bauer. Okay. And so we throw these discs that are impregnated with the different drugs. You remember doing this simulation. There's another one on Connect for you to do. And then you measure the zone of inhibition, right? And then you compare that to a chart, right? And you find out whether it is resistant or sensitive or no effect. Neutral. Okay, and that will depend on how broad the zone of inhibition is, right? The resistant are going to have the smallest zone. The sensitive are going to have the biggest zone. Okay. And that allows you to pick out what kind of drug you should use to treat. Okay. So there's some examples, right? Resistant, intermediate, susceptible. Okay. Which you could also call sensitive. Okay. And that tells you what to pick, right? Based on, again, diameter of the zone of clearance. Okay. So what's going to happen for the actual practical is I'm going to shoot you guys. It'll be a PDF and it will have pictures from both the labs that you've done and from this, which is being recorded and which I'll also send you for you to answer the questions. All right. And they're going to be, some will be fill in the blank and some will be multiple choice, true, false. And then you'll just complete that and you'll send it back to me and I'll grade it. Okay, so there's no time limit on it. You're doing it at your own pace. And you can use your materials to help you out, all right, to get through it. I'm guessing it's going to be about 30 questions probably. Okay. And like I said, when you get it back to me, I'll load those grades up. Okay. That's really all I've got. We're actually past time. Does anybody have any questions before we jump out? Remember that I'm going to put all those Connect grades in. And I'm going to get you, I'll get you a PDF of this that we just looked at. And I'll also get you the keys to the homeworks that I've sent out. All right. After you've sent your completed homework in. And I think that'll help you study up and be ready. And the lecture midterm, like I said, there's going to be a practice midterm up on Connect that I'm actually in the process of building right now so that you can take that before you take the real midterm. And it will be from the chapters up through last week, equal number of questions from each chapter. Okay. And I'm giving you, I think, 2 shots at it. And I'm going to give you, it's timed, but I think I'm giving you like 2.5 hours to get it done. So it should be plenty of time to get through it.
Okay.
Yeah. So does anybody have any questions before we bump?
How many questions will be on the lecture midterm?
Lecture midterm 50.
Okay.
Yeah.
And what's the due date for that?
May 5th.
May 5th. Okay.
So you got time.
Okay.
All right, guys.
All right. Thank you.
Questions? Thank you. Thanks for coming.
No problem. Thank you.